Welcome everybody for this evening's session on voice issues related to thyroid cancer surgery. This session is supposed to help everyone learn about voice issues, those that are temporary and some that are more ongoing. And of course, everybody's welcome and you'll have the opportunity to get your questions answered. We're going to tell you a little bit about ourselves first. Dr. Ho, if you wouldn't mind explaining the Head and Neck Society.
Sounds great. My name's Alan Ho. I'm co-moderating this with Daria and Gary from ThyCa, representing the American Head and Neck Society, or AHNS. We're a group of head and neck surgeons, many of us whom focus on thyroid and parathyroid surgery and thyroid cancer. We are delighted to be here. We strive to really improve patient outcomes as well as do our best from a surgical perspective for this disease. So we actually are very lucky to have a group of physicians who have donated their time with special expertise in voice outcomes and voice rehabilitation after thyroid surgery. So maybe we'll go right to introductions. So again, my name is Alan Ho from Cedars-Sinai in Los Angeles. Why don't we move on to Vinny? You want to say a little bit more about yourself and what your expertise is, and we'll go from there.
Hi, everyone. Good evening. My name's Vinny Dillon. I am a laryngologist as well as an endocrine head and neck surgeon at Johns Hopkins in the Washington, D.C. area. I did 2 fellowships, so I have a little bit of a unique clinical practice. I do a lot of endocrine surgery, but I also do a lot of laryngology. So hopefully I can be helpful in this topic tonight.
Highly relevant for this topic, for sure. Karuna, do you want to introduce yourself as well?
Sure, thanks. I'm Karuna Dewan. I'm a laryngologist. I'm at LSU. My practice focuses a lot on rehabilitation after head and neck cancer. So speech and swallow rehabilitation after treatment of head and neck cancer, including thyroid and parathyroid surgeries. So.
Excellent, thank you. And then Miriam, last but not least, for the physician side.
I'm Miriam O'Leary. I'm a head and neck surgeon at Tufts Medical Center in Boston, and thyroid and parathyroid make up a decent proportion of my practice at this time.
Thank you. We're also very lucky to have another specialist on the speech language pathology side. Claire, would you be able to introduce yourself? I think you'll have a really important role to play in today's conversation.
Yeah, my name is Claire Ligon. I'm a speech pathologist that works with Dr. Dillon at Johns Hopkins in the Washington, D.C. and Baltimore regions. I'm a singing voice specialist and vocalogist as well, and I see a number of Dr. Dillon's post-thyroidectomy patients and also see a number of performers and singers.
Yeah, well, we'll jump over and just describe what ThyCa is before we do introductions. So just a little bit about us. We are the Thyroid Cancer Survivors Association, and we are a nonprofit organization, and we're dedicated to all of you out there for support, education, communication for the survivors themselves, their families, and their friends. We have a mission, and that's to educate and support the global thyroid cancer community and invest in research. And our vision is a world free of thyroid cancer. And I'm happy to introduce Anjali Kapoor-Davis and James Arsenault, and I will toss it over to the two of them. Anjali, why don't you go first and introduce yourself?
Sure. Thank you, Daria. My name is Anjali Kapoor-Davis. I'm a 19-year thyroid cancer survivor patient, still trying to get rid of it. I'm REI resistant, and I facilitate support groups for ThyCa as well as being a board member for ThyCa.
Thanks. James, how about you?
My name is James Arsenault. I'm from the Belfast, Maine area, and I'm a 6-year anaplastic thyroid cancer survivor at this point. I'm still fighting the disease, as Angela is also. We lost use of my left vocal cord because of the impact by the cancer mass when it was originally diagnosed in 2017 and surgically removed. 2019, I was introduced to Dr. Burns, who did a cortex insertion to the left vocal cord, and my voice is better than it was, but it's still nowhere near where I was before the cancer took the nerve.
Thank you so much. We'll have lots of time to jump into all those details. First, let me describe a little bit about the agenda and the format. We're going to pose some general topic related questions to all the panelists, and the panelists will answer them. But at the same time, you are free to ask additional questions. Please put them into the Q&A box. Avoid the chat unless you're truly just chatting with people. But the Q&A box is what we'll be monitoring. Try and keep them general. Avoid putting your personal information in there, all the nitty gritty details. And if I see similar questions, I might try and combine those topics. I see we have a question submitted already, and we'll try and weave it in as it makes sense. And we'll try and stay on topic. We want to do topic related questions. And just a reminder to everybody that this session is being recorded, and we'll put it out on YouTube in short order. So let's jump in. What types of voice issues may arise from a thyroidectomy, and are the risks the same with a partial thyroidectomy?
Great. Why don't we start maybe with Dr. O'Leary, just as a general, this is more of a general question, and what you encountered during your operations and the post-op care. Mm-hmm.
Sure. So voice issues that can arise from a thyroidectomy can either be temporary or permanent. Weakening of the voice where it's weak, breathy, difficult to make yourself heard, or a raspy quality. And injuries that are short-term are generally nerves that are intact but irritated and recover from that irritation over time. Longer-term issues are typically nerves that either never recover from that irritation or were actually cut during the surgery, and so will never function again. And the difference between a partial thyroidectomy and a total thyroidectomy would be if the nerve on one side is at risk of injury versus the nerves on both sides.
Great, thank you. Karuna, since you have more laryngology subspecialty training for question one, are there other sorts of voice issues that you encounter when you see this after the surgery, either your surgeries or others?
Yeah, I think Dr. O'Leary's answer was great. So there's a couple of different things that come up. We talk a little bit about hoarseness or really loss of voice or loss of volume. But the other thing that comes up often can be difficulty with pitch and pitch management. There are two different nerves actually that run very close to the thyroid and can be at risk. There's the recurrent laryngeal nerve, which would be responsible for that general motion and the motion of the vocal fold. But when we talk about pitch changes, we're talking about the superior laryngeal nerve, and that can come into play sometimes too, where there's really no change in motion of the vocal fold, but the ability to change the pitch and express emotion and things like that may be impacted. And that also tends to play a role more for singers, people who professionally use their voice, and is really more of a concern for that group of people.
Okay, so shall we jump on to question number 2?
Yeah, I think so. It's a good segue. Mm-hmm.
Okay, so what tools are used to avoid voice issues? And sometimes in the thyroid cancer community, we hear about nerve monitors. What are your thoughts about using a nerve monitor?
Very good question. Hot topic, maybe in the past, not as much anymore, but still very relevant. Vinny, do you have any thoughts on nerve monitoring or other techniques to avoid voice problems?
Yeah, I think just to answer the first question, what tools can be used to avoid voice issues? I think it's always important to discuss the fact that voice can be affected. I think, Dr. O'Leary and Dr. Dewan mentioned all the potential anatomical and functional issues that can occur, but it's important to address that as that there is always a risk, and that, the best tools that we have can be employed preoperatively, intraoperatively, and postoperatively. And so for a lot of us that do maybe more laryngology or have maybe a laryngologist right next door, if we're seeing patients, we do what's called a video stroboscopy sometimes preoperatively, especially for our professional voice users, including singers, speakers, lecturers, because a video stroboscopy allows us to really see not just anatomy, but functionality of the voice before we put a patient to sleep. And sometimes we can kind of clue in if there are some deficiencies or functional issues that make it worse, that may or may not be related to the thyroidectomy, but from, you know, in terms of like injury, but like healing after a surgery. And so that helps, at least for me, get someone like Claire involved sometimes for my professional voice users to kind of give them an idea of what it would be like in the rehab portion. And then in terms of nerve monitor, I use a nerve monitor every time. It doesn't really matter what type of surgery, just because that's how I was trained. And I think most of the generation of endocrine surgeons coming up, that's kind of our, you know, bread and butter is using a nerve monitor. I think it's the best tool we have out there to help us really know if there is a potential for injury, with the understanding that we know how to use the technology, because that's also very different depending on what kind of monitor you use. But, you know, it does help to know if we're able to have a signal, but is that signal changing through the surgery? And is there going to be a risk for either a temporary or permanent problem? So I think the nerve monitor is a very important intraoperative tool. And then post-operatively, I think, again, a video stroboscopy is important at some point if patients' voices aren't getting any better, or getting them in to see a laryngologist or a speech language pathologist, and then rehabilitation as best as we can early on.
So Vinny, I really like what you're talking about with the video stroboscopy. I think it's a key distinguishing difference between, say, otolaryngologists like head and neck surgeons compared to other surgeons. Can you, in a way, I find that it's helpful, and you mentioned this or began to speak about it, and that it may identify things that the patient doesn't notice, but that the surgery unmasks and afterwards makes things more challenging, or becomes more apparent, right? But it was always there in the first place. Can you think of a few examples of other problems or diseases that that became an issue, and the patient just happened to have a thyroid cancer or thyroid surgery as well?
Yeah, I mean, I think if we're thinking about a professional voice user, someone who has high vocal demand, I mean, it could be a singer in general. You know, we always want to rule out any sort of vocal fold lesion, typically a phonotraumatic or benign one, for example, nodules, a vocal fold polyp, maybe some scarring that already exists in that patient. And we can pick that up typically with a video stroboscopy over the typical scope that most patients may receive in an otolaryngology office. But that does help us understand that, you know, maybe even if a patient doesn't have a voice complaint per se, they're used to their baseline voice, we're anatomically able to say, you know, there is something there, and this may not go away, but, or may, you know, your voice may worsen functionally, even on a temporary basis, because of that underlying pathology that already exists after a thyroidectomy. Because with thyroid surgery, most thyroid surgery, you know, surgeries are done transcervically, or, you know, with an incision in the neck. So there's a lot of scar, there's a lot of muscle tissue healing, there's a lot of functional things that normally will happen. But if a patient has an underlying pathology, it may make their voice worse. But we're able to have that consent process be much more informed and more relevant for the patient if we're able to kind of pick that up preoperatively and have a better patient satisfaction, and hopefully get them into the right rehab post-op.
Excellent.
So somebody submitted a question, and I was going to ask it too. Can you describe what this video stroboscopy is? Like, I'm not familiar with it, and maybe you could describe what does the patient go through when they go through that process?
Sure. Maybe we get Karuna, if you do a video stroboscopy, maybe you could describe it just to get a word in.
Absolutely. So I offer this to a fair number of patients who they have either some voice complaint prior to a thyroid surgery, or they're having a revision thyroid surgery. It's kind of standard in that practice. So what it is it's a camera, and it's basically a spaghetti diameter camera. It goes in the nose, and we use it to look at the vocal folds. And it's flexible laryngoscopy. The stroboscopy itself is a special kind of light. It's a strobe light, and it allows us to see vocal fold motion better than just plain white light. So the vocal folds move faster than the human eye can really appreciate. So the strobe light slows that process down, essentially, allowing us to see how the vocal folds come together. I think it's really important for people with thyroid cancer to visualize the vocal folds before surgery, because oftentimes patients may not notice a change in voice. The thyroid grows so slowly many times, so insidiously, that there may not have been an appreciable change in the sound of the voice or vocal effort, but in actuality, there may be some difference in vocal fold mobility that we can't necessarily hear. So it's really important to have that preoperative information. I think that changes how we manage, how surgically we manage things sometimes.
Excellent.
Awesome.
Maybe we could also ask Dr. O'Leary, again, the second half of this question, the nerve monitor. What is your take on it? Is it superfluous? Is it indispensable? How do you use it?
Similar to what Dr. Dillon said, I trained with it, so I use it on every case. There was a general surgeon at my institution who was doing these for many years, and he trained many years before me when they didn't exist, and took great care of patients without it. So I think that there has been a shift over time towards this becoming more standard. And there's been, like you said, it's been a hot topic, but there have been some large series that have shown an overall benefit in terms of lower rates of injury to the nerve using a nerve monitor.
Yeah, I completely agree. There have been excellent studies that show a mild to moderate benefit in terms of preventing vocal cord injury and paralysis, and those are pretty well established. I would tell patients, just like you, I have colleagues who still don't use nerve monitor. They do very well without it. I would kind of use the parallel of like the example of like a GPS when you drive. You don't need GPS necessarily, but it probably makes your life a whole lot easier. For me, when we do surgery, sometimes the nerve may be underneath some tissue and you can't quite see it. But the nerve monitor, if you it can help you map where the nerve is, help you find the nerve faster and more safely, rather than perhaps finding it through the old-fashioned way. So I think there are definite advantages to the nerve monitor that I think today pretty much make it a standard of care, and I don't think that's controversial to say.
If I could toss in one more question before we move on. If there's nerve damage and voice changes, can there also be an effect on breathing?
Oh, that's interesting. Well, maybe Vinny, maybe you want to, or Karunas, you unmuted first. I'll give you first crack at this question.
Sure. I read that question in the chat box and was thinking about it. So I think this goes back to the first question where we're talking about the difference between total thyroidectomy and partial thyroidectomy. When we operate on both sides of the thyroid, the recurrent laryngeal nerve is at risk on both sides. And airway or breathing becomes an issue if both recurrent laryngeal nerves are injured, then neither vocal fold moves, and we have a question of sort of glottic stenosis, or the inability to breathe through the larynx or through the glottis. That's sort of one cause of breathing difficulty. The other is if you have a paralysis on one side, patients will often feel short of breath when they're speaking because a lot of air is escaping through the glottis, escaping through the vocal folds that are not able to come together, not able to close in the middle. We'll have some loss of air, and so people will have difficulty finishing sentences or difficulty walking and talking at the same time. So there's a couple of different ways that shortness of breath can happen in this setting.
Okay. So just a reminder to everybody, you're already doing it. I see the questions in the Q&A box, but if you have some, feel free to toss them in there. So Anjali and James, here's a question for you two. If you would be willing to share, what types of voice issues have you had, and were you able to sing after your thyroid surgery? So Anjali, why don't we start with you a little bit about that, especially with the singing?
It's been interesting to hear the doctor's perspective on that. So yes, I had the vocal cord paralysis on the right side after my first surgery, which was a thyroidectomy and a radical right and left neck dissection. So it's the ear to ear scar. I had soft, breathy voice after surgery, and some difficulty with some swallowing issues and choking on kind of everything. And at that time, they didn't actually put me through the consult part, which I wish I could have met someone to go through that. But I think it just really depends on where you're at. If you're not at a Center for Excellence, like most of our doctors here are today, and in a smaller town, that can affect that ability to have access. As far as being able to sing after thyroid surgery, I was a classically trained vocalist, and am no longer, due to the range shrinking down to about 5 or 6 notes, and I don't get any louder than this, without extreme challenges, coughing and irritation to the voice. I do have an ability to speak, although my volume is low. I think it's been able to utilize that by working with a speech therapist. So that's been a huge help. But yeah, it was very painful, not just the literal pain, but the devastation of losing that part of life and enjoyment. So I appreciate that a lot of you are putting that effort into making sure that your vocalists are taken care of. I certainly hope that more physicians do the same.
Thanks, Anjali. How about you, James, to tell us a little bit more about your story?
So I had really wispy voice from 2017 when I had the surgery till 2019 when I had the cortex inserted by Dr. Burns. The issues that I ran into was that, and I still do, if I'm in a crowded room and there's a lot of noise, it's hard for people to hear me. When I go through drive-throughs, they can't understand me. I a lot of times have to stop my car. And I will say that the center I was at, Mass General, they had a speech person available, and they consulted with me as to what was going to take place with the loss of voice, but we weren't sure if they were going to be able to do anything because with ATC, typically there's a 3-month expectancy for survival. So we waited a year to see how things were going. And since I was doing good, they put me through the surgery and my voice was improved to where it is now. I am tired after 10 or 15 minutes of continuous talking. Crowds are still difficult, but we certainly appreciate the activities of you doctors and specialists who work with the surgeons to make sure that the nerves are tried to be damaged as least as possible.
Thanks for that, James. Okay, for all of you survivors out there, if you want to share your stories, not in the form of a question, but if you want to share, we are monitoring that. If you want to put any of your stories in there, some of you have in the form of questions, and we will get to those. So this question, what expectations do you give to your patients about the short and long-term impact on voice?
Yeah, I think this is a pretty important question, whether you're a singer, actor, or even just someone like, a stay-at-home mom, right? There are various expectations that people have. And I think oftentimes it's the physicians who set them. So maybe Vinny, do you maybe mind giving us a snapshot of what you tell patients before surgery?
Yeah, I mean, I think, when we talk about short and long-term impact on voice, we have to put that into the context of if there is a nerve that will be injured, and is it one or both nerves? Because like Dr. Dewan mentioned, if you're going to undergo total thyroidectomy, you're technically putting each nerve at independent risk. And we can't really, we really can't skirt around that issue that each nerve has its own independent risk. We have to be very mindful of each of those nerves. So In terms of the voice, you know, if there's an anatomic injury whereby the recurrent laryngeal nerve is affected, what's the likelihood that it recovers? And I think this, again, really depends on the surgeon operating, what they see in terms of, you know, is there a pull on that nerve? Is there a heat injury? Because we use sometimes a lot of cautery and devices in the operating room that can injure the nerve. Is it, you know, there's, you know, compression against the nerve? Are we actually going to cut, you know, is the nerve going to get cut? And so each of those prognosticates the potential for short and long-term impact on the voice. So technically, you know, within 3 months, we expect a temporary, if there's a weakness to the vocal fold, it recovers if we believe that, you know, there is something that is going to be a temporary weakness. If it's obviously permanent, we want to address that immediately with a patient post-operatively. And that again relates to the anatomy of those nerves, and injury to those nerves. But I think if we're thinking bigger picture, we also have to think about functional issues with the voice. So if there's no nerve damage and, you know, we were to take a look post-operatively and everything looked great, what is the potential for this patient still having, hey, you know, I can't talk as loud, or I'm having fatigue, or it's getting better, but it's not perfect. What are the timelines for those types of recovery? And I think that's a little bit harder. We can't kind of put months or years on that, but we have to address those things. And I'm very frank about, you know, if there's any post-operative between the time I see my patients at 2 weeks, 1 to 2 weeks post-op till like 2 months, if there's any voice concerns, I want you to come back. And I scope and I do, you know, strobe, and I get my speech pathologist involved if I have to, but I don't want it to linger if I know that everything anatomically looks great. And that to me is still a short-term impact for the voice. Hopefully though, and a lot of papers that have looked at this suggest that within 6 months, even those functional things get better, but we still need to address them. So maybe you're telling a patient, everything looks great anatomically, but functionally you may have issues for 2 months, 3 months, but by 6 months, we're hoping it gets better. So, you know, it's a little bit, we have to follow our patients, I think, a little bit more diligently, whether or not it's an anatomic issue or just a healing, post-op healing issue.
Great, thanks. Miriam, let me maybe hone down the question so that you can answer in a more general way. Let's say it's a garden variety standard patient, not someone with special voice needs, and let's say we expect the surgery to go well. Of course, everyone still seems a little leery about, you know, is my voice going to be gravelly? Is it going to be the same? If everything goes smoothly, and it's a standard patient, how do you kind of frame it for these particular patients? How do you expect, what do you tell them in an expectation for when it'll be back to baseline?
Yeah. So I always tell patients that right after surgery that they may notice a change. I describe it as a froggy quality to their voice, and that's related to the manipulation of the airway for the breathing tube. It's a bit of a slightly bulkier tube that sometimes requires slightly more manipulation to get it in than breathing tubes that are used for other surgeries. And some folks do have a fair amount of basically an acute laryngitis just from that bit of manipulation. That's very short-lived. But if patients wake up and they're, you know, what does my voice sound like? And they notice a difference, and you think this is something acute that's going to go away pretty soon, but you haven't kind of prepped them for that ahead of time. I feel like patients can go through a little bit of unnecessary anxiety with that. So I tell them about that impact that they might have in the first few days. And then in terms of expectations for a true short-term limited mobility or lack of mobility of a vocal cord or a pitch issue from the other nerve, I phrase that based on what I know about the surgery I'm going to do, where the nodule is located, how aggressive it appears on the preoperative imaging. Does this look like something that has a chance of being really stuck down to the nerve that's going to be a more challenging operation, or if this is a nodule that really is far away from the region of the nerve, looks very well circumscribed, don't anticipate a difficult dissection, and those influence the the percentages that I quote to patients about how likely they are to have a short or long-term voice issue after surgery. So it really, for me, is a case-by-case basis for the nerve injury expectations, but I do tell all patients that they may notice that change in the first few days after surgery that is truly temporary.
Excellent, excellent. And Karuna, we've spoken about the standard patient. Do you say anything different to, say, a weatherman or a professional singer, someone like, say, maybe Anjali, who is a professional voice user? Is there anything different you tell them?
So the professional voice user is kind of like an athlete. They're very in tune to their instrument and they notice differences that even I don't notice. So that's kind of how I approach the situation, that there will be differences. It will feel different. I like to get people into voice therapy with my speech pathologist very quickly, very soon after surgery, because I think that it's like you wouldn't run a marathon after having a knee replacement. So I'm not going to ask you to give a lecture or sing after you have a thyroid surgery without training and without going back to the gym. So I really like to work in concert with my speech pathologist to treat these patients both before and after surgery.
Excellent.
The questions are coming in fast and furious. I think we should maybe knock out a couple of them. There's a couple related to breathing. Are there any ways to treat the shortness of breath that comes from the vocal cord paralysis?
Vinny, do you have any thoughts on that one?
Yeah, and I think it goes back to what we see on the video stroboscopy, like Dr. Dewan mentioned before. Let's assume it was just a single or unilateral vocal fold paralysis or paresis, meaning one side is fixed or not not moving. And I think that goes back to the air escape, especially with speaking or exertion and speaking. A lot of us laryngologists, I think do like to see our patients that are post-op having these issues sort of quickly, because usually they have a very large gap between those vocal cords. And if we're able to perform what's known as a medialization, I mean, and one of our patient advocates here, he just mentioned a Gore-Tex implant, but like an injection in the office, which is more temporary. Sometimes not just the voice issue, but some of these breathing issues can be resolved. So we're kind of close. It's like a leaky valve. We're kind of closing it. And so that air escape is gone. And so I think that's something, again, early intervention or even early rehab with a speech language pathologist to close that gap can be very useful in terms of a treatment option. Bilateral vocal cord paralysis is a little more complicated, obviously, because it's kind of a fixed issue and you're breathing through a straw. And so, that takes a little bit more nuance, and that's, individual, every patient we have to take on an individual basis. But, if we have to bypass that with a, tracheostomy, even temporarily, that's obviously the safest way. But there are other interventions we can do if it becomes more permanent.
Great. Daria, I think you're muted, but you wanted to knock out another question or two from the chat box?
You're supposed to say rookie mistake like you did last time. Yeah, that's because I was typing to somebody. So yeah, I think we should jump to this question because it might help answer some of what's in the Q&A. Are there medical treatments to help improve the voice? And does seeing a speech pathologist or a laryngologist help?
Perfect. I think maybe we should cue our speech pathology expert, Claire. Maybe we'll start with you. Just get right into it, because your skill set is so unique and exotic and specialized that it would probably be really nice to have the 50 or so people on this webinar to kind of better understand what you do. Well, go ahead.
Absolutely. So I really appreciate how Dr. Dillon and Dr. Dewan sort of introduced a little bit about what speech pathology does, sort of like, a knee replacement. There's rehab to be done to address 3 different aspects. Really, you have the edema immediately after, and the wait time that it might take to help facilitate the improvement in voice quality that patients will see initially. And then as things heal, there may be some scar. And so tethering of the larynx that could also affect pitch. And so we do mobilization of the tissue to help break out the scar a little bit, maybe do some manual just to help get some mobility to the larynx so that that really finely tuned instrument can feel better for those singers that Dr. Dewan was talking about that, may sound still really good to everybody else, but, in their own body, especially as a singer myself, when we feel slightly different, you can hear it sort of in your head, but other people can't. And so that's where you really have to key in on what your patient is telling you, follow their lead, and do your best to mobilize that tissue, but not just then from the outside. That third part is the voice exercises. So knowing that if, there's nerve involvement, there is going to be a change in function of one of the vocal cords. And, depending on the degree of that change in nerve involvement, you may do, more intensive exercises or exercises with head turns to posturally allow the stronger vocal cord to compensate. And hopefully over time, either have the stronger vocal fold compensate more consistently, or see if you can coax the weaker vocal fold to start to move, and then facilitate ways to compensate for that change. And if it's a very minor change, then giving exercises just to facilitate return in range, more consistent fundamental, or that just regular speaking pitch that you've been speaking at for a long time. Some patients will say, even if the nerves had been intact, that after the intubation, they may have a functional change in their voice where their muscles actually start to squeeze quite a bit, despite the fact the nerves, again, are okay, though for some reason those muscles have squeezed too much. And so we actually teach them how to reduce that compensatory strain to get their regular vocal cords moving again, and giving them a stronger voice with less fatigue, where that muscle compensatory muscle tension actually was causing the fatigue. And when they reduce it from, let's say, guarding because of the discomfort postoperatively or from the swelling, they actually find that they have a much stronger voice. So it's a combination of dealing with the functional issues and being able to get their voice range back and balanced, depending on the nerves that have been involved, getting the tissue mobilized, and then helping to counsel them along the way to support them and advocate for themselves throughout the day, to use amplifiers and to rest as needed immediately after, to do excellent vocal hygiene, to drink plenty of fluids, just to facilitate that healing.
Hey, Claire, I wanted to ask, you're talking about muscle tension dysphonia. It seems like, it almost seems like as if some thyroid surgery patients develop bad habits. If there's any message that you could tell post-operative surgical patients about something you wish they would stop doing in terms of a bad habit, can you tell us what that would be?
I think you're implying whispering. That is one thing, or just generally not talking. I think we know that in laryngology practice now, that we're constantly trying to tell people that using your voice is better. Motion is lotion. That will facilitate healing. It will move fluid through the tissue. You don't want to rest, because that actually can reduce the muscle conditioning, and that if you whisper, you might get into sort of a tension pattern over time, and you're not really using your voice normally. So yeah, you want to just talk, just maybe not speak as loudly at first and gradually increase.
Excellent. And Karuna, can you tell us what you do in conjunction with the speech pathologist to work together? How is it coordinated? What is your role when it becomes necessary to engage the two of you?
So I'm fortunate enough to have a speech pathologist in my clinic with me. So we see new patients together, which basically means my speech pathologist, who is lovely, will take a history, talk to the patient about, what has happened to them, what struggles do they have with their voice, how has their voice changed, and what help would they like from us. And then I do the exam. So I do the scope exam. I look at the vocal folds. We talk together about what we see, what we hear. We do a comprehensive voice exam together. And so essentially we get an idea of loudness, pitch range, ability to project. What I like to tell my patients is when you're done with me, I'd like you to be able to order from a drive-through and talk on the phone. Two things where people can't see your lips. They can't see your face, but they need to understand you. So that's my goal for my patients. I usually start with speech therapy. So we see the patients together. And for people who have a small glottic gap, like they have, just a small bit of room between their two vocal folds and they sound breathy, or someone who's had a change in their pitch range, they'll start with voice therapy. And they spend several weeks working with my voice therapist. And then they'll come back to me and we'll talk about how happy they are with their voice and what's new and what's different. And then we'll talk about some other interventions if the therapy has not sort of addressed the issues that they're having.
Great. There's a whole world that I'm sure many patients have never encountered before, but it's extremely illuminating. So Daria, are there other questions on the chat you want to cover?
Oh yeah, there's somebody here who's had a tracheostomy and is speaking quite well using false vocal cords, and is asking if he could have like speech therapy. Is that possible?
Well, Claire,
Yeah.
what is your take on that? Go ahead. Mhm.
Yeah, absolutely. It would, if it's something that you haven't had in the past, then it's certainly something that you could explore in terms of your options. The false vocal fold phonation is definitely a tool that some patients will use if their vocal folds are not, if the nerve's been paralyzed, and so the vocal fold isn't moving. And while it can be functional, it can be very limiting and very fatiguing. So I think it would be an option for you to explore.
Awesome. So what about laryngospasms? I don't know if I'm saying that right. Is there a way to help somebody that has spasms? Apparently they're very scary. And this person has already tried vocal therapy and it hasn't helped.
Yeah,
Any
Dr.
suggestions?
O'Leary, do you have much experience with this? It is a rare but a known phenomenon.
Yeah, agreed. I think a skilled speech language pathologist is extremely helpful in this scenario for respiratory retraining therapy. And in my experience, that's been one of the most effective ways to manage this.
Very good. Somebody's kind of looking towards the future. Is there any research happening on ways to repair a damaged nerve? And do you foresee anything in the future?
Oh golly, yeah, there've been quite a few paths trailblazed, but maybe they haven't quite come up to fruition. I don't know, Karuna, Vinny, maybe this is something you've seen, whether it be the deinnervation, reinnervation, or even transplant approaches. Anything that you've seen down the pike that looks interesting?
There are a lot of people at different institutions working on it. I know, across the country at UCLA, and then a couple groups in New York and in Boston. There are people working on this. Oh, and in Indiana as well. But I don't know that anybody has anything that's clinically applicable. We're working in terms of animal models and things like that. But I don't know that there's anything clinically applicable at this point. I think that's the direction that we're moving in.
Karuna, what do you think about, let's say a nerve was transected and not repaired? Would you, and maybe this again is investigational, but would you ever consider someone with a poor voice outcome going back in, finding the nerves and trying to reanastomose with maybe a cable graft or some other nerve, just so that there's continuity?
Yeah, I think the time course is important. So we will go back in within a week or two. Anything really much longer than like a month, we're not going to get great great results. But the purpose in doing that reinnervation, and most often I will use this nerve called the ansa cervicalis, which supplies some of the strap muscles. And the purpose of doing that reinnervation is not to restore motion, but rather to give tone to that vocal fold that's been denervated. So if you leave a vocal fold without a nerve supply, it becomes, and if you look at the arytenoid, which is the attachment, I like to tell my residents that it becomes sort of sad looking. It bends over, and it's kind of sad that it doesn't have a nerve supplying it.
Oh no, she froze.
Yeah, she froze.
Um,
Oh dear.
Vinny, would you want to pick up what she was about to say and maybe what your take is on reinnervation? I'm sorry.
No,
Sorry
yeah,
to-
hopefully
yeah.
she'll pop back in because I don't want to finish her sentence because it's a really good point. But yeah, reinnervation, the goal of the reinnervation really is to provide the muscle tone. So, after a muscle, any muscle in the body loses its nerve, it undergoes some form of atrophy. And that includes not just the muscle that the nerve is innervating, but the whole complex. So as Dr. Dewan was mentioning, the arytenoid is the joint, the actual kind of like the elbow joint or the shoulder joint, but it's our joint in the larynx. And so what happens to that joint, because everything is sort of, it's kind of becoming like wilted or flaccid, is that joint kind of hangs, it becomes, like she said, sad. And there's an atrophy to the vocal fold. So the whole point of reinnervation is not so that, we see this vocal fold and the joint moving like it once was, unfortunately, but that there's like this bulk to it, this tone, so that hopefully that the good side makes better contact with a bulkier muscle. And so, we like the likelihood of requiring further intervention after the reinnervation, like an injection or a medialization to push it over even more, is high. But at least in the long run, as things heal, that contact is likely going to be made once that reinnervation happens. And so a patient is going to have a better voice outcome at the end of the day.
Thanks, Vinny. Karuna, anything more to add before you were unceremoniously cut off?
Dr. Dillon did a great job summarizing exactly what I was getting at, and my computer restarted successfully. So.
Great. Any other chat questions, Daria?
Oh, there's 10 of them in here. I don't know that we're even going to be able to get to all of them. One person is saying that they're a year out from their total thyroidectomy, and they get fatigued. Their voice does whenever they use it in any extra way. It's exhausting. Would therapy this far out from surgery be beneficial?
I see Vinny nodding vigorously. What is your perspective on that question, Vinny?
Yes. The answer is yes. I mean, even after a year out, I know lots of us see patients that, have compensated, and, there's something that's still just off, and, it's at that point permanent, unfortunately, if it's a vocal cord paralysis, but there's so many functional things that can be improved upon. I know Claire touched on this, but everybody's compensation is different. And so it might be that the vocal fatigue is not because your vocal cords aren't actually able to make contact. It might be that you're squeezing, you have muscle tension, and that's inhibiting you from getting the best mechanics that you have with this vocal cord paralysis. And so doing therapy at any point to, unload that or to help with the functional component is only going to help. And if it's not a strong, if it's like a weak vocal cord or atrophied vocal cord, and the goal is to strengthen it, the therapy will help even after a year. So I think the benefits are definitely, there's no risk. So it's definitely beneficial.
I mean, I think what Daria, this chat is telling us, and the theme emerging, is that there's this beautiful subspecialty within ENT that could really help patients. And I'm sure there are plenty of surgeons who will talk to a patient long-term and say, what's done is done. There's nothing that more that can be done. But this webinar and all the panelists are really encouraging patients to say, no, more can be achieved, and it's not over. So even after a long-term surgery that has been performed a while ago, there's still more that can be done to improve voice in many situations.
Absolutely.
Mm-hmm.
So one question is from somebody who's been taking Keytruda, and the side effect is extreme muscle weakness. So it's aggravated an already bad situation. and their voice is a whisper and breathy. Any suggestions for them?
I mean, that's a pretty, Claire, I don't know if you've ever experienced with Keytruda. I think that's a pretty uncommon situation. It may or may not even be related. Have you seen anything like that before associated with this drug?
No, not specifically myself. I've had patients who, well, I don't think specifically with Keytruda. No, not that I'm aware. Dr. Dillon?
I mean, I think I don't know, again, I don't correlate it to the drug itself, but the fact that if there is a patient that had, extreme muscle weakness related to the medication, I think a lot of us have seen some patients also with sudden weight change, usually weight loss and voice change. And again, it's probably maybe more of a muscle atrophy thing is what I'm thinking. And it's hard because, we'd have to obviously examine our patient to know, but if there is any sort of muscle weakness or muscle atrophy related to the drug or otherwise, it can definitely lead to changes in voice because their muscles and their whole function to create resonant sound is to make contact, right? I mentioned the leaky valve. We don't want a leaky valve. So if there is a little bit of atrophy or weakening of the muscle, and it's related to a gap that's not present, then that could be the reason that there's a change in voice.
And I will say that, if I may jump back in, if, you were talking about voice, it's also connected to the power source, your lungs. And so if there is general muscle fatigue and deconditioning and whatnot, then it may also be a matter of breath support behind the voice that's also affecting it.
Excellent point. Daria, do we want to move to question 6 and get our patient advocates' opinion on that last one?
Yes, absolutely. What tips do you have to help us with voice issues?
No, maybe James, do you have any insights on answering this particular question?
I find that keeping my mouth moist helps with the sealing of the vocal cord. I've got the left one is fully closed, so that it's just the right one that's got to function. And sometimes stretching the neck one way or the other way will help recenter the vocal cord so that it seals better.
Okay. And thank you. And Anjali, any tips?
Yes, absolutely. So right off the top, I would say, like, I've got this headset on for the Zoom session, but portable wise, and no, I don't get paid for any of this. Just gonna say that off the top. I have it's a little headset, and then I don't know if you could see that, and then it attaches to this little speaker. It clips onto your pants, or hold on to it. And I use this because my dad's hard of hearing. It's really hard to communicate sometimes with the volume of my voice. That's been really useful, especially in crowd settings too. As James mentioned, keeping a mouth moist, so good old Biotine. That's a go-to, as well as teas and things like throat coat. And no, I'm not doing like product endorsements. I'm just gonna say that ahead of time. It's just, this is what's in my house and this is what I use. The tips and techniques that I learned from the speech therapist was really helpful, learning how to start a sentence, taking a breath, releasing a little air, letting that warm air warm up the vocal cords before actually uttering the sentence or words that you want to say. So I really think that that's vital, and I really wish that it was standard of care to see a speech therapist after, as well as a physical therapist, because a lot of people have mobility issues as well. So I'm hoping at some point that'll become standard of care. But those are some of the tips that I have for getting through this process.
Excellent. Thanks, Angela. These are things that aren't written down in a textbook, or it's just something that you come across with experience, and it's really great that you're able to share this with our other patients today. Daria, any other last questions as we head to the end of the hour?
Yeah, I think there are so many and some of them are so specific that I've taken some screenshots and we can try and maybe get some quick answers, and I could weave them into the video after the fact because we just don't have time. I will put in a plug for the Thyroid Cancer Survivors Conference. The 27th International one is coming up this September. So we're actually having it during Thyroid Cancer Awareness Month. Very exciting. And it will be in Houston, Texas, and there will be a virtual option. So just wanted to remind everybody about that. Stay tuned to social media for details. We'll roll them out as soon as we have them. But for now, just mark your calendars. And speaking of marking your calendars, we have more webinars like this one coming up in June, September, and December. And I just want to give a heartfelt thank you to everybody, our panelists, our audience. You kept me hopping today with all these questions. It's more than we could keep up with. But it just shows you how important this topic is. And thank you, everybody, for helping us understand it more today.
Yeah, 100%. This topic is underappreciated, underrecognized, underacknowledged. The panelists here just represent a sliver of all the ENTs out there that have special training in this, and then subspecialty training. Vinny, Karuna, Miriam, they all understand this in ways that I think I wish other physicians and other patients could understand. And hopefully this will get the word out that there is a lot to be gained by seeing someone in this specialty. Absolutely. Great. Well, thanks, Daria. We want to thank the participants as well, and hopefully we'll see you on June 13th for the next round.
Yep, sounds awesome. Thank you, everybody.
Thank you.
Take care.
Yeah.
Thank you
Bye.
very much.
Thank you. Thanks.
Thank you.